sort of a flow chart here or a sequence of events to describe that. So the osmolarity of the extracellular fluid, that can be detected by the osmoreceptors, the OVLT regions of the brain where there's no blood-brain barrier. And so in response to that, we can increase the neurosecretory hormone, the neurosecretory cells, right, the neuroendocrine cells of the brain to allow the hypothalamus to make more of that ADH, send it down to the posterior pituitary and secrete it into the blood. From there, it will travel to the kidneys, bind to the receptor on the basolateral surface, stimulate the upregulation of aquaporin 2 channels that allow for water reabsorption in those distal parts of the kidneys. That will decrease how much water is excreted or lost, and that basically conserves the amount of water that is eliminated, which can be a negative feedback response to a drop in blood pressure, a drop in blood volume, or a drop in mean arterial pressure. Okay, so that can essentially increase our blood volume, pressure, etc., and then turn off that initial trigger, which is a negative feedback loop. Similarly, these two responses can trigger that entire sequence of events as well. So not only the OVLT regions of the brain, but the baroreceptors can detect this change. They detect a drop in mean arterial pressure or a drop in blood volume. Let's say someone is bleeding out, we have some hemorrhaging, or there's severe dehydration. That will be detected by the baroreceptors. They will respond by triggering the hypothalamus, the nuclei in the hypothalamus, to secrete that ADH once again, releases to the posterior pituitary, travels to the kidneys, inserts more aquaporin 2s, reabsorbs more water, water excretion goes down, and that same sequence of events can turn off these two signals as well, which is a drop in mean arterial pressure and blood volume. So both of these same sequence of events, just two slightly different triggers, one being detected by the baroreceptors, one being detected by the OBLT receptors or the osmoreceptors in the brain. And then to think about the role of the gradient here again, right? The whole role of water regulation and the water reabsorption is to help with modulating the change in GFR. So GFR, again, is very tightly regulated. If we have a mean arterial pressure or blood pressure between 80 and 180, our GFR is tightly regulated in that window. Now, if blood pressure drops less than 80, we are going to see a drop in GFR. And that is because we're going to have less water being filtered, right? Less plasma volume to begin with being filtered across the glomerulus. And then overall, we're going to have less water excretion in terms of that lower blood pressure. If we have a higher blood pressure above 180 millimeters of mercury, we're going to see the GFR increases. So we'll have a rise in GFR, we'll have more water being filtered across the glomerulus, more water being excreted, and essentially more water being lost in the urine. These two states are pathologic states, okay? So don't think about them as normal, although they are part of our normal physiologic response. They're not a part of homeostasis. They're not a part of our steady state response. They're more occurring in pathologic states. So if your blood pressure drops lower than 80, this is not sustainable. This is getting into the territories of hypovolemia, of shock, right? And this can happen in the face of, as I mentioned, hemorrhaging, bleeding, dehydration. But the response of the kidneys is to decrease the GFR in the face of that much more drastic blood pressure change. The same thing is true for higher blood pressures. This is also more true for sustained higher blood pressures. If your blood pressure rises to 180, just transiently, let's say you're, I don't know, you're excited or nervous or anxious, or you're um, in a state of shock, or you are in a state of I don't know, sunstroke, right? Any type of condition that can raise your blood pressure transiently will not necessarily bring about this response. What will bring about this response is sustained hypertension. So folks that may have chronic hypertension, right, that is ongoing and uncontrolled with medication, their blood pressures live in this range of 180 millimeters of mercury. And so this is what we're going to see. Their kidneys are going to start to fail because there's an increased GFR. Kidneys are working harder. They'll be losing more water because they're filtering more water because of those higher sustained blood pressures. Okay, let's look at two of these checkpoint questions here briefly. So name two stimuli for ADH release from the posterior pituitary. So we just described the two main triggers or stimuli for ADH release. Can we recall those two stimuli? Okay, so in short, it's the first trigger is the osmolarity of the blood that is traveling past the osmoreceptors, the OVLT region of the brain. The second trigger is the mean arterial pressure and blood volume of the blood passing the baroreceptors at places like our carotids, right? Our carotid bodies. So those two triggers stimulate ADH release, and then the response is pretty much identical. The response, which is question two, is the effect on the principal cells. The principal cells are the distal part of the tubule, distal collecting duct, and convoluted tubule, and it is to insert more aquaporin 2 channels on the apical surface of the membrane to facilitate water entry into the apical surface of the epithelial cells, and then by the aquaporin 3 channels, which are permanent in the basolateral surface, water can be reabsorbed across the basal surface and then into the blood. So the ADH role is to increase the aquaporin 2 channels to facilitate water reabsorption.